Hello, everybody. Today, I'm going to talk about the management of epilepsy in 2023. This talk will be beneficial to people from medical school, fresh graduates, practitioners, physicians, neurosurgeons, neurologists who deal with epilepsy patient. And since I'm a neurosurgeon, I will also, and doing epilepsy surgery, I will touch a little bit more about epilepsy surgery in this lecture as well. But then I will talk about, in general, how to manage, what are the possibilities, what are the limitations, and what are the future of epilepsy management. Because epilepsy is such a fascinating disease, and it is changing in such a big way that we all need to, those who are working in this field should know the update of how to manage epilepsy. So before I talk about the epilepsy in general, I want to talk about the perspective of how you look at science in epilepsy. And I would like to talk about two scientists. One is Democritus, and another is Socrates. Democritus is he's a mechanist. He believes in science, and he talks about whatever happens in a cell body, it happens from inside. So it has to be there. There should be some explanatory mechanism within the cell. And Newton is a big follower of Democritus. Whereas Socrates say these, cells are being influenced from outside. So the outside force, which is not seen in a very good way, in a bigger way, that is more important than the, whatever mechanism that we study within. Because we'll come to a wall where you will not understand how the things are moved. So this concept is equally important if you want to go further into management of epilepsy. Just like the slide shows, this is a matter, which is a chunk of iron. And but then if you put a magnetic field on this iron particles, then you will see that there is a structure and there is a pattern. So if you remember the previous slide, if you go back to your previous slide, then matter is something which is inside, which exists, but then field is the one which makes it into total. So I think we need to understand this fact. And we need also to understand about electricity as a whole, to understand epilepsy management. And amino acid was formed from different chemicals that were present at that time in the earth billions of years ago, when an electrical spark in the form of lightning was struck on these chemicals. Then there was a chemical change. The electrical sparks worked as a catalyst, and then amino acid was formed. And then this chain of amino acid eventually became RNA, then converted that into a more genetic material like DNA. And the first cell that we ever saw was almost 3.5 billion years ago. And the first action potential that we saw, from where the cell became something which is active, and not only living, but active. This is the starting of action potentials. And so that was about a billion years ago. And then that was added on by evolution into making vertebrate, where there was a lot of minerals, calcium deposited within the body, which make them more mobile, so that they can move or fly or swim and move from one place to another. So this is a kind of evolution. And electricity in the body, generation of electrical current in the body, is the starting, I think, point of the whole evolution. And one of the oldest living organism is a jellyfish, which you can see, and where you can see that the giant axon, very long axon, one single axon, you can actually dissect it out if you catch these fishes. So it was, many years ago. So now the brain is constituent of all these neurons, billions of neurons, and like a jelly. And these neurons carry electricity, and this electricity is passed on to another cell in the form of chemicals in synapses here, and then it'll generate another electricity and another synapse and another chemical. So it's electrochemical, sort of things. And so, it covers so much. All our movements, all our activities, all our thought process are governed by this electrochemical signal. And when these electrochemical signals become abnormal, then we have epilepsy or seizure. And somehow, many of these psychotic diseases are also now thought that these are limbic seizures. So whenever you have electricity that goes through a pathway, then you create magnet. So when you think about epilepsy, you should think about electricity, chemical, and magnet. These are the three things that you need to remember. Now, talking about the action potentials, the resting action potential is minus 70 millivolt because of the active sodium potassium pump. I don't want to go into detail about that. And then there is, gradually there is a sodium influx, and then the threshold potential of minus 50 is well, and then you have action potential spike, which can be recorded in a recording system. And otherwise, once the action potential is here, there's a depolarization, and then it goes into depolarization and comes to a resting potential, and then it will have another action potential. Once that is generated, then you have that goes into another dendrites. So there are excitatory postsynaptic particles and inhibitory postsynaptic receptors, and sodium, calcium. Basically, glutamate is the excitatory and GABA is the inhibitory. So if you have more glutamate, then this chemical can cause more, action potential going from one place to another, whereas GABA inhibit. So there should be a balance between these two, So talking about the definition of a seizure, first, a sudden uncontrolled electrical disturbance in the brain. It can cause change in your behavior, movement, or feeling, and also in the level of consciousness. And if you have at least two unprovoked seizure occurring more than 24 hours apart, then we call it epilepsy. And one unprovoked seizure and probability of further seizure similar to the general recurrence is at least 60%. So somebody who had a lifetime seizure, they should be watched pretty carefully till 10 years because the chance of repetition is about 60%. And if they have another seizure, then we say, okay, this person have epilepsy. And if there is some first-time seizure and if there's an epileptic lesion, then they will qualify for definition of epilepsy without having a second seizure also. So what causes seizure? It's a long list, but then about 15% of people have some kind of genetic trend. If you do a genetic study. And first, in these people, there's 3 times of having a seizure in first-degree family members. Metabolic, obviously structural, some damage or some congenital defect, infection, autoimmune antibodies, idiopathic or tumor, anything, any insult in the brain can cause seizure or swelling. These are the two responses that the brain invariably have. And there are some triggering factors like lack of sleep, stress, alcohol, recreational drugs, fever, flashing or flickering light, periods. Some people have seizure during monthly period, and if they miss meals, also they have seizure. And as we all know, idiopathic epilepsy is going down, and we are detecting more and more seizure, which were in the past thought that is a psychiatric disease. So because of good imaging technique and other EEG technique, we are detecting more and more of non-idiopathic epilepsy cases. Some risk factors like complex febrile seizure, if the duration is more than 15 minutes, one seizure, more than one seizure in 24 hours. If there's a focal seizure, one side of the hand or leg or one part is moving. And if there's a history of epilepsy, head trauma with loss of consciousness, meningitis, encephalitis, these are, risk factors, and also perinatal distress with hypoxic brain insult. These are risk factors for epilepsy. So if you have one seizure and then there is, people who have history of this, then you need to watch them closely. So if somebody has a first seizure and if the EEG is normal, if the CT is normal, or preferably MRI is normal, then the risk of having another seizure within 1 year is 14%, 3 years, 29%, 5 years, 24%. So this means that if you add up, there's a 66% chance that the patient will not have another unprovoked seizure. So these are not candidates for treatment if they don't have risk factors, and if they have only one seizure, EEG is normal, CT scan is normal, then 66% chance that they will not have seizures. So you can just say, okay, we can just wait and watch this patient. So, but then there are rationale of starting medication, even if there's a previous neurological insult, a sibling has epilepsy, generalized spike in EEG, or if there's an acute symptomatic seizure. Now, how does seizure is generated and propagated? So the most important part is the ictal onset zone where the epilepsy starts. It's just like a tsunami, epicenter of an earthquake. So there is abnormal electrical activity in one part of the brain, and it tries to spread out. And but then there is always inhibitory, GABA inhibitory response immediately around that area. So there are a lot of epileptic discharges that is coming in our brain all the time. But then this inhibitory program works, and then it inhibits that seizure in that place. So we don't have a clinical seizure. But then, like small tsunamis or small earthquakes, we are having this all the time in our brain. But if that inhibitory part is not strong enough and the seizure core is more strong, then it spreads out, and then it can propagate from one place to another and become generalized. So we call it, and then if somebody has more seizure again and again and again, then we call it kindling, just like firing wood. So then we have a network of pathways that is generated, which will spread the epileptic focus either from the same place and get bigger and bigger and faster and faster, or it connects through the connectomes into different regions of the brain, so that you have more kindling or more fire in different places. So the more seizure that you have for a longer period of time, these two effects get uh, augmented, and then you have more of intractability in seizure. So once you have this epicenter of seizure, as I have said, there are different pathways through it, through which the seizure propagate from one place to another. Just like in this case, there is a generation of epilepsy from one place, and it has moved through corpus callosum to the other side of the brain. And maybe initially the patient had focal seizure, and then it became generalized. Or if it is starting from the temporal lobe, the hippocampus, then it can spread out and maybe either localize into the temporal lobe and patient do not lose consciousness, or it spread to the whole brain and then eventually may lead to generalized seizure. Or even in the center of the brain, it can go and spread into the both sides. So the most important part when we study epilepsy is we should try to get the idea where the epilepsy is originating in this particular case. And secondly, we should know how the epilepsy is propagating from one place to the other, which is the pathway that it is taking. So there are different clinical symptoms that can guide us, or there are different investigations that suggest, which I will talk in my subsequent slides. Now, these are some of the pathways: anterior fasciculus, inferior longitudinal fasciculus. These are a lot of, connectomes, and these connectomes take the epileptic activity from one place to the other place in the brain. So now these connectomes can be studied by Human Connectome Project. So you can, meticulously study all these things and then try to get into understanding of where it is originating from and how it is spreading. Now, the latest classification of 2017 by ILAE, International League Against Epilepsy, they have divided epilepsy into three general modes, and they have talked about onset for the first time. So because onset is where the epilepsy starts, and that is the most important thing, and we all are interested where it is starting. So that way, it's either it's a focal onset to start with, it's a generalized onset, or maybe it's a unknown onset. And there are, whether there is a awareness or impaired awareness, a motor or non-motor symptoms, and blah, blah. You can study that on your own. And now talking about once you have a diagnosis that this is seizure, now it has converted into epilepsy, and maybe that this is focal onset or generalized onset or unknown onset seizure, then you should start a medication first. And the medication, before you start the medication, you should, as I've said, it should be confirmed that this is epilepsy. EEG may be normal. It's okay, because EEG most of the time on a OPD basis, you study for 15-20 minutes, and these can be missed. At that time, the EEG may be absolutely normal, but the patient is still having seizure. But then you should classify the seizure type and start first general first line anti-epileptic drug. Don't go to second line, third line anti-epileptic drug. First generations anti-epileptic drug, one drug, monotherapy, and start with low dose and gradually increase till the highest tolerable dose. If lowest possible dose is working, then don't go too high, okay? And my idea is not to add, but if that drug is not working at all, then you should stop that drug and start another monotherapy. Because adding two drugs means one should work, but not enough. Then you can add another to get that synergistic effect. But if the drug is not working at all, then it's a waste of, you are just giving complication to the patient. So it's better monotherapy, monotherapy, monotherapy. And sometimes patients come to you with multiple drugs that they have tried in the past. Then the best thing for you to do is to ask them which drug worked best for you. Then they'll give you the answer, and then just use that drug. That is because you don't know which drug works on which patient. You can yes, you can. There are some ideas, but then it is not a foolproof idea. So it's a heat and trial sort of. Basically, it comes down to heat and trial. Okay. So if a patient is still having seizure, then maybe you should go for polytherapy. And let's say some drug like phenytoin, let's say. Phenytoin you started and then it's an enzyme inducer. So it was working for a long, long time, but then suddenly it stopped working. Then I just stop that drug for some time so that the enzyme of the liver comes back to normal, and then restart the same medicine. And during that short period of time, 3 months, about 3 months, we give some other alternative drug. So I call it drug holiday because phenytoin works best, or any other drug worked best. You should try to continue that. That's the best drug for the patient. Had no complications, and the seizure was well controlled. Then, but only problem enzyme is induced. Then you stop it for some time and get back to the another drug, and then restart the same drug that was working. And I will again explain more than three drugs hardly work. So if we, you have already started three drugs, then think of something else to manage that patient. So different, anti-epileptic drugs work on different things. Some work on multiple channels, some sodium channels, some GABA, augmentation, some glutamate inhibition, and calcium channel opener, and this and that. So, and there are, if you want to combine, then there should be logical combination of two drugs where you missed another action. Then you can add these two together so that you also augment. Otherwise, same sodium channel blocker, same sodium channel blocker may not work. So you should think how to combine drugs like this. So what is the chance of epilepsy being completely controlled by anti-epileptic drug? So people, let's say people with epilepsy, first drug, 47% of people will become seizure free with first drug. This is published in New England Journal in 2000, and 53% are uncontrolled. So you add, then you increase another 13%. And again, 40% are still uncontrolled. Then you add another drug and do different things. And at the end of, even if you add more and more, it's not going to work that much. So the percentage of seizure-free gets lesser and lesser with new drugs, but then you are adding possibility of more complications. So then that is the time you should think of labeling this epilepsy as a intractable epilepsy and think about starting some kind of other therapeutic methods. When we talk about epilepsy, we think this is bad. We think about only bad things, but it's not always like that. Many famous people had lived in this world and then has become, were excellent professionals in their respective career, but they had seizure. So some examples like Leonardo da Vinci, Vincent van Gogh, which made Starry Night when he was having seizure, Napoleon Bonaparte, Beethoven was one of the big music composer, even Sir Isaac Newton, many people say that he has seizure. Julius Caesar himself had seizure. Charles Dickens, who is a famous writer from England, Alexander Great, Alfred Nobel, Aristotle. These big peoples, I can, give you a lot of names, but I just picked the most famous people here. There are some controversies that they may not have seizure, but I have studied their life, and then I am sure that those days the diagnosis of seizure was only generalized tonic-clonic seizure only, but these people were like Vincent van Gogh. He used to go into spells of angriness, or he just walks out of home and gets disappear, and then he vandalized his own body and even cut his ear. So these were during these spells of epilepsy. And I want to give another example of Daniel Tammet. This gentleman was a normal person. He never had seizure, but one day he had a very, very bad temporal lobe epilepsy. And when we wake up, then he became very, very genius in mathematics, which he was not, And then one day he tried to calculate pi, 20 day, and then he could, give the decimal for about 5 hours continuously. And eventually he stopped because he said, now I'm tired. 5 hours is too much for me. So sometime, the electrical activity in the brain opens up different channels so that you become a better person. So we don't know many of these, extraordinary, brilliant peoples that I have just expressed here. They may have their excellent ability to think beyond their age, may be contributed by epilepsy. And most of these peoples are synesthetic peoples. Synesthesia means you perceive sense in a different way. So maybe synesthesia, they had synesthesia, which is in some time, this is a kind, could be associated with epilepsy. So synesthesia, epilepsy. So we are still understanding these things, and maybe one day we understand better, and we understand the how some people are better than others. Maybe, I think maybe, I believe it's possible, and think this abnormal electrical activity, we call it abnormal, but we can call it a supernormal or super electrical activity, give them superpower to do different things. So investigation for any epilepsy are, basic is first is EEG, and I recommend MRI. Even first seizure, I recommend MRI, not CT scan, because every seizure has got a first seizure. Every seizure is a first seizure. So if I have I have done MRI and found first seizure, many tumor case, many AVM case, many disease which needs immediate action. So if we think this is for just first seizure, just forget it, then you will miss. So whether to treat or not to treat, you can decide after all these tests. So MRI and simply EEG is enough, because EEG may not be positive during the period of time that you do. But it's better to have EEG with a sleepless night, and then when you are doing EEG, let the patient sleep so that the background activity is less, and then you have the possibility of catching up. And talking about MRI, you have to have a EEG seizure protocol, and best is 3 Tesla MRI, because first time if you do a MRI and you say don't do it good, then you may miss the pathology. But you say, oh, I already had MRI, so I'm normal, but then you may miss the pathology. So if you do, you should properly do then you can do a video telemetry, which is a very good way of 2 or 3 days you can put the patient in a video telemetry system and then study them together. I'll show you some examples. And then you can do a electrocorticography by doing electrocorticography, closing it up and then leaving it for some day, or you can do ECOG during surgery, which is the technique that we generally use in our institute, or depth electrode. Now, there is growing evidence that stereotactically implanted small micro electrodes like this, many electrodes in the brain, works much better. So everybody is now, if you think of epileptic surgery, then you are going for stereotactically implanted multiple depth electrodes. Now, how is electrical recording of the brain is done? Scalp EEG, if you are detecting about 30 to 500 millions of neurons from one cap, and If you do ECOG, you can do ECOG like this. You are closer to the brain, so your amplitude is more, the muscle artifacts are not there, the scalp deaugmentation are not there, so it's better. And you can also do SEEG, where you put a depth electrode, and or MER. Sometime I've done single neuron recording, and see how the neurons are firing. So basically, you are trying to get the electrical activity of the brain and as precisely as possible. And so about semiology, if you look at this gentleman, this is a typical case of temporal lobe epilepsy. He's having seizure. Sometime he is lost. He's partially talking, but then most of the time he's on his own. And it looks like he's trying to read, but then he's not, it's totally. Another time he is. So this kind of bizarre behaviors for a short period of time, and they can go out of their house, walk around, leave their place, and but they are having constant epilepsy seizure of the temporal lobe. So, seizure in ways. This girl came to us with a very big hypothalamic hamartoma, and she always laughed. So it's called gelastatic seizure, and then had a generalized tonic-clonic seizure also. But before seizure, she always laughed. Some people only laugh and stop. So these are three cases that we have done in this way. So we took stereotactically targeted the hypothalamic hamartoma and did MER recording of the hypothalamic hamartoma. It's a microelectrode recording, and we could see that there was a bizarre, very highly firing neurons within the hamartoma. So we knew, okay, this is the focus of our, this seizure. So what we did was we burned this area with electrocoagulation from the borehole, and then burned it out, and then she became normal. Sometimes they can present with a very, very strange type of behavior, where this gentleman kept on laughing and laughing like this, and after surgery he stopped laughing when we remove this. So these are very, very rare cases. It's not a common case, but I just want to make my point here that these patients can present in a very, very strange way. So these are also epilepsy. This patient is having a brainstem epilepsy that is starting from the brainstem. Brainstem can generate epilepsy. Cerebellum can generate an epilepsy, although it's a rare occasions. Now, talking about video, this is a temporal lobe epilepsy. This girl is already having epileptic fits here, mainly from the left side, and her right hand is not moving. She's having a very big seizure, but the lady there is the occupant there don't even know that she's having seizure. And then now she understands, okay, then she has seizure. So seizure can be gradual like this. Takes time, takes few seconds to develop, or maybe sometimes minutes to develop. And then now she never lost her consciousness to that extent, and now she is almost back to normal. And as you can see, her EEG is also normalizing. So this is another case of epileptic seizure where both sides is suddenly involved. Both brains are generally suddenly involved, and they have a very, very big generalized tonic-clonic seizure. And there's a lot of muscle artifact, obviously, but bilaterally synchronized epilepsy, you can see suddenly bilateral. Or this can be slow, like electrical seizure, which is proceeding. And then the left side of the electrical is building up, and then he's turning his head towards the left side, and he's gradually turning, and we call it a figure of four positioning, and then he has generalized tonic-clonic seizure. So there is a build-up from left side. It gradually went into right side, and then became generalized. Okay, so these kind of seizure most of the time originate from the frontal lobe. So there are some lateralizing signs that the patient may give you a hint, and then you may think, okay, this patient is having seizure from this side, like sensory aura, sensory motor cortex, hemifacial visual aura, visual cortex and adjacent area, different things, like ictal drinking, ictal aphasia is obviously aphasia is language area. Ictal vomiting is non-dominant. Ictal spitting, some people just spit. Figure of four, I just post-ictal nose wiping like this. This is also a very, very common of temporal lobe epilepsy, ipsilateral. So if they do like this, then right side is most of the time involved. So there are different ways of guessing where the epilepsy is coming from, because this is most important, where the epilepsy, and next important is how it is getting propagated. As to read EEG, this is not a lecture for that, but then you all should, if you want to work on epilepsy, whether you are a physician or a surgeon, even surgeon, if you want to operate, you must be able to read your own EEG. Somebody else read your EEG and give it to you. I don't think that's a good idea. At least you should understand, or you should confirm yourself that whatever the neurologist or epileptologist has worked up, and then you also agree with their idea. If you don't have that basic epilepsy idea, then you may end up wrongly. So here you can see that there are different waves. As we go down, we go into higher and higher frequency, like deep sleep, sleep and dreaming, and so delta, theta, alpha, beta, gamma. Gamma is the highest, and we say in meditation we go into sleep. No, we are in meditation where our brain is most active. We are fully aware. If that is, then that is meditation. If you start sleeping, that is not meditation. So then now a new technique I will again talk about, this is high frequency oscillation, which will very nicely tell you about epileptogenic zone. This is 1020 system, which is the standard way, and most of time you can have different montages, but referral montage is all the referrals. Referential montage of the referentials are either in one right ear or left ear, and longitudinal, like double banana, you go flow like this and like this. So you see the difference from FP1 to F7, FP1 to F3, and from F3 to C3. You see the difference in these two, and you can also plot this and see where these are representing in the brain itself. So when do you see abnormal EEG? So to see an abnormal EEG, you need to at least have 108 neurons abnormally firing in one place. Only then you see. So small epilepsy, small abnormality in your brain, you don't even detect by EEG, So all these neurons, like if they have synchronized, just like this, synchronized abnormality from neuron 1, neuron 2, neuron 3, so on, then you see a sum of abnormal EEG like this, which has got a, or if it is, it's not a desynchronized type of irregularity, then you don't see anything. And so that's normal, alpha, beta, theta, gamma, these are normals. But then epileptic form discharges also have different patterns, like spike, or they may have spike and wave, or polyspike, 2 spikes here, maybe 3 spikes sometime, and wave, polyspike and wave, 3 hertz polyspike and wave, 2 hertz are smaller, very, far, and polyspike, multispike. So these are, different things that you need to study on your own if you are interested in this. Now, one word about high frequency oscillation. This is the latest biomarker of epilepsy, and mostly used by studying some invasive procedure, but also you can do it by normal EEG. And once you study the high frequency oscillation, so if there is gamma inhibitory interneural activity, you have high frequency oscillation, which can be ripples or fast ripples, depending on, so 80 to 250 hertz. Most of the EEG machine that we buy only have can record up to 100 hertz. And but then we are generally studying in 70 hertz, So these machines these are special machines with special filters where you can record 80 to 250, and 250 to 500 hertz are fast ripples. And so if you want to have this study, then you need to have an EEG machine which can record up to at least 1,000, 15,000, 1,500, or preferably 2,000 hertz. It should be able to record. Then you can study, and these are very, very good indicator of epileptic zone. Now, if you study video EEG for a long, long time, it's very, very difficult to study all of this at one time. So you have to, bring everything in together and use AI technique to see where the patient is having. Like this is the Persist AI software that we use, where we have seizure, and then you can see from where it is originating. And if you go to that place, then you can see exactly, the phase reversal on FP1, F7. So where the epilepsy is coming from. So if you have a repetitive pattern, then okay, FP1, so frontal lobe on left side is abnormal. So software incorporation is very, very important. Now, EEG again, here F for rhythmic theta wave, you can see there abnormal theta wave, interictal, but then gradually that built up, and when you have seizure EEG, video EEG, and you have a seizure, then you can actually see where it is coming from. So this is a very, very good indication of where the abnormality is arising from and how it is spreading to the other side of the brain. Another is F3, origin seizure that is very short-lasted, not very long. Now, talking about epileptic zones, there are different epileptic zones that you need to understand. First is the seizure onset zone. If you can know where the seizure is originating from, the epicenter, the tsunami, that's the best. But then once they have seizure from one area, then you have epileptic zone, not seizure onset zone, but epileptic zone. So epileptic zone is best identified by high frequency oscillation. So that's why high frequency oscillation has become a biomarker. Seizure onset zone is best identified when you do a video EEG and see how it is building up and where it started. And then you have functional deficit zone where the patient says symptomatically, I have this when I have seizure. So it's only part. It may be bigger than where the seizure is arising. So if you can just remove that part, then you can make the patient seizure free. But with long time, then you may have irritative zone. And this irritative zone is the interictal discharge. So it's not very sensitive. Interictal discharge can give you a hint, but it will not give you exactly where it is coming from. And you can add functional MRI to see where the seizure is coming from. Like this is one of our case, and which is about 22 millimeter away from the right leg area. So we can plan accordingly. Leg and hand area accordingly. SPECT is a good technique that you can add to identify where the seizure is coming from. SPECT, you can do ictal SPECT also. So when you do a ictal, when you are having seizure, you do a EEG SPECT, and you see a hot spot there. And when you are not having seizure, then that has got less metabolic activity. So you'll see a cold spot there. So this is also how you can do. So late post-ictal is best, ictal is best, and then interictal also you can see. And if you can have FDG PET, then you can detect where the MRI is normal, everything else is normal, MRI negative, but then you can still detect by hypo function by using fusing the software FDG PET and MRI and detect out. But then this detects only anatomically. You have to prove it by EEG and also by semiology, the clinical symptoms. And recently, there's a more development on magnetoencephalography, which is generally coil that you know use like this, and then you look at the magnetic, as I have told you in the beginning. There is a direction of the magnet that flows. So if there's an electrical activity, there's a magnetic flow, which is detected by these very, very sensitive magnets. And now they have also have MEG, which you can wear, and then you can actually real time see what's going on in the brain. So different things are developing, and one of the case where there is a electrical activity, magnetic activity in one part of the brain, and that has spread gradually to the other side. And I don't know why this is moving, not moving. Let me check. Yeah. So it's like it's moving like this. So from one brain. But here is another case where there is not moving. It's limited to the temporal and maybe partly to the frontal lobe. But here it is moving from one place to the another. So there it is generalizing, whereas in the other case it's focally managed. So once you have the information about imaging, EEG, and symptomatology, then you can create a triangle. If all these triangles meet and point to the same, let's say, left hippocampus, semiology also say, okay, left hippocampus, EEG also say left. If it is concordant, then you can think of doing surgery on those intractable patients. So intractably, very simply, I will say, if you try more than two drugs for more than 2 years, then the chance that the patient have cure from seizure-free is very, very low. So you should think of going for a epileptic study for surgery, and if it matches, becomes concordant, then you should go and do surgery. But now I add ECOG in this study because ECOG, intraoperative ECOG, gives a very, very big, strong evidence. So I want all these four triangles to meet. In many centers, they use chronic depth electrodes or surface electrodes for a long time and then go and open it again. But in our center, we just do it during surgery. We take a little bit of more time during surgery to study and then wait. And we have been, in 80% of cases, this has helped a lot. So just few examples of a 18 years boy with, uh, focal temporal lobe epilepsy, partial onset, and then a flare. You can see that there is a hyper signal in the left hippocampus. Amygdala looks pretty okay, and then body of the hippocampus towards the tail also there is high signal. And this is the video where you can see that the patient is already having seizure, but then he is, still moving and doing his things. So it's called automatism. He's doing something automatically, but he's not aware of what he's doing. Or in another instance, he has, again seizure, but then he don't fall down or he's moving about, but he's already having temporal lobe epilepsy. So this is our first case. We did it, this surgery in 2002, almost 20 years. He had a very classical right temporal lobe epilepsy, and he was on multiple drugs, socially handicapped, and was not going to any school. These days, we only had 0.35 Tesla MRI, and now we invariably do these studies on 3 Tesla MRI, which is better. But then, if you can see by any MRI, it's okay. But then false negative, you should remember that there will be false negative cases also. Now, 20 years, he's living a normal life. He never ever had a seizure in his life after the surgery. So here we did a ECOG. Here we are doing ECOG, and so we are doing this ECOG from different places, like base of the anterior temporal lobe base. There are some interaxial discharges. This is bipolar, this is monopolar. And here, from the hippocampus, there's a periodic firing from the hippocampus, a lot of firing. And 1, 2, 3, the lead 3 is the one which is active. Amygdala was pretty silent. So, you can actually do this study by small leads, putting only on head of the amygdala, body, tail, and then know what's going on, and then try to tailor your surgery according to the ECOG, intraoperative ECOG. And then you may have to remove the whole. This is the first case that we did, where we did a 6 centimeter anterior temporal lobectomy, which is a classical sort of treatment for right-sided. Left side, we do about 4 centimeter. And we also included hippocampus, amygdala, everything in these cases. Now, sometimes we are doing selective surgeries, not always like in this case, where you can see that, the MRI is pretty normal, but then, with the it was firing from. So MR negative, sometimes we do something like this. And then intraoperatively, we study the lateral temporal structures. And if they are normal, we just leave them behind. Another MR negative patient where both of the temporal lobe looks normal. And this is scalp EEG, which shows maybe it's a phase reversal in T3, F7, not very clear, but maybe. So sometime in such cases, we put a bilateral bar, make a bilateral burr and put a stereotactically or neuronavigation based implant of the depth electrode and do a 1 day, 2 day EEG, and then you clearly see that on the right side, in bipolar, left side bipolar, it is firing. So this patient was, we did a water test, and his memory was on the same side where he was having epilepsy. So we did a multiple hippocampal transection in this case, but eventually he recurred, and then we had to take out the hippocampus as well. And then he did well, and his memory was also okay. Another patient where he's having a focal seizure all the time for almost 4 days like this. And there's so much seizure that he's having pain, It's mainly the pain. And if you look at the MRI, then there's a cortical dysplasia here and cortical dysplasia here. And T1 here, 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 and here. So an EEG was also suggesting the same place. And he was on carbamazepine for Feritone, Levera, and carbamazepine, 3 drugs for more than 2 years, and the seizure was not being controlled. So this is intraoperative ECOG, where we studied, and also we did a depth electrode during surgery. And since this was a child, we wanted to do awake surgery, but this was a child, so awake surgery was not possible. So we removed the frontal area by navigations, and then EEG tailored, and then disconnected the rest, these 2 centers, by a vertical incision on the frontal parietal connections. But this patient continued to have seizure so we waited for 2 days, but then he continuously had seizure. So we went again and then removed this central part also, which was actually not focal cortical dysplasia patient, but then he was having seizure from that part also. So we had to disconnect that part also, and then he became seizure free. Now, another presentation that we see is a drop attack. This is here the patient will, the father knows that the girl is going to have drop attack, so he's trying to hold it, just fall like that. She is having 30 falls like this per a day. And another seizure where, the girl is having a similar seizure, almost 40 per day, So they have this atonic seizure or drop attacks, and then they wake up and then they just move on. So these patients, we can do a complete corpus callosotomy if they are children. I do complete corpus callosotomy in adult also, because I find it, but there are people who only do anterior 2/3 and leave the posterior 1/3 for later surgery. But in our country, people don't want 2 surgeries. So, and doing a complete corpus callosotomy at one time, you may think of worry about having a disconnection syndrome, but then I don't see it much. It's not a big problem. Initially, for about a month, they talk less. If you talk with them, they talk, but then they won't spontaneously talk, because the initiation of the talk is from the right brain, and the talk itself is being done by the left brain. So that disconnection makes them talk less. Otherwise, they are not, at all handicapped. So example is a boy, he had multiple falls and multiple injuries, and about 10 to 12 falls a day, and then he broke his bone, and then his mother now is tired of taking him to the hospital for every fall. So he had open wounds like this. There are child who are the mother also tried a helmet on this child. So just we do uh, corpus callosotomy, where we completely cut the both side of the brain from right to left and disconnect the whole of the brain. And you should, once you go through the corpus callosum, you should like that. And another case where we did an emergency corpus callosotomy, this boy had a hemiatrophy of the brain, maybe childhood, asphyxia or ischemia. And he had continuous seizure first. He was on status epilepticus when he came to us for 4 days. And everything was tried. Barbiturate coma was tried, but then that didn't work. So we took him into emergency corpus callosotomy, and then his status epilepticus stopped. And now he is having focal seizure, but not big generalization. So this is how we recorded both sides of the brain and did a corpus callosotomy. And recently we have started doing, when there is no lesion that can be removed, you cannot localize the lesions, or there is a bilateral temporal lobe epilepsy. So these are the cases where you can do a vagal nerve stimulation. Most of the time, when the generalized seizure, if you think this is originating from one side of the brain, we do a total callosotomy first, and if they fail, then we do a vagal nerve stimulation, VNS. And so, medicine, about 75%, maybe less, become seizure-free. After surgery, our record is about 80% of them become seizure-free. VNS have a lesser effect, about, because you put VNS on more difficult cases. So it only works on 66%. Anterior thalamus or mediolateral thalamus stimulation, another 50% you can cure. There are other techniques like closed loop stimulation, which I don't have any my own experience, and neurofeedback, or biofeedback. And there may be other, techniques like ketogenic diet, meditation, and radio frequency listening or laser listening, things like that. So at the end, I would like to say that, in this epilepsy program that we have, we do, medical management, we do all kind of, other biofeedbacks, education also. But then when it doesn't work, then we go for surgery. And now we are thinking of more of DBS or even anterior thalamus listening in very difficult cases. So I think you don't need to know where your goal, is goal setting. I don't believe in that. And if epilepsy is one of the path that I have taken, and if you are just be in the right path and continue to learn from other people's experience, then you will reach where no one else have been. And this is a picture of our residents, and who are having a very, very good exposures in all kind of surgeries in our institute, including epilepsy surgery, DBS, and lesioning, radiofrequency lesioning for Parkinson's, for tremor or writer's cramp, or even psychosurgery. So if any of you are interested for a short visit, you can communicate with us. Thank you very much for your attention. Thank you.